Okay. Um, do y'all want to, this is the most important stuff. Should we take a break real quick? Let's knock this out. Now, like I mentioned earlier, this acid-base thing is really highly tested. So we'll kind of break it down and work through these equations. So y'all have learned the Henderson-Hasselbalch equation. Basically, if the hydrogen is attached to the acid, it's not charged, which is opposite for the base. If the base is not attached to the hydrogen, it's not charged. You can see here, hydrogen plus acid is not charged, base plus hydrogen is charged, okay? So this breaks down when we start talking about the different drugs and how they are regulated. So okay. Yeah, so the body uses buffers, primarily bicarbonate, to regulate the change in pH, right? So bicarbonate can be shifted using carbon dioxide and whatnot or carbon dioxide can be transferred with bicarbonate as bicarbonate. And bicarbonate, because it has that, it's in that buffer region with the pKa right around here. I think this was more of a term one problem. You don't really need to worry about it too much now, but because it has a pKa right around this normal range, it works as a good buffer. And you can see that here, they do ask this 20-to-1 ratio of base to acid, this buffering system. So it's good to know that. Yeah. And then if y'all remember, I might have it, yeah, it's right here. If y'all remember this graph, if we do logs of the pH, every time you change the pH of one, it's a 10-fold increase or decrease. Okay, and that's what's calculated with logs. Okay, so if they ask you about drugs, you know, the trick I use instead of using this whole thing is that if it's an acid and it's in the stomach, which is acidic, you would think it would fall in this range. Okay, so that's how I do it. And so if they tell you an acid and you calculate this and it's say 2 and you know you're in the stomach, you fall in this 99% is going to be absorbed range. Bases are absorbed in the intestine. So if it's a base in the intestine, it would be in this range. I'm going quickly through this because this is just review from term one. What's much more important is this stuff and the acid bases. So excretion is the opposite of absorption. So for it to be absorbed, it needs to be lipophilic. It needs to be not charged to go through the GI or the stomach or the GI system. But for it to be excreted, it needs to be charged so it stays in the urine. So when it goes through that liver and it does the second pass, it actually puts a charge on it. It's no longer active and it's able to get into the urine and as an ionized form or a charged form so it can be excreted. All right. Again, this is just buffering system. Let's see. Okay, so respiratory problems, the main thing to remember here is you treat carbon dioxide as an acid, okay? So if you are hyperventilating, you're decreasing carbon dioxide, right? If you're hyperventilating, you're blowing off the carbon dioxide. So that means you're getting rid of acid, so you're in a state of respiratory alkalosis, okay? If you have hypoventilation, right? So you're not breathing out carbon dioxide as much. You're holding on to carbon dioxide. That means increased carbon dioxide. Remember, we're treating it as an acid, will lead to respiratory acidosis. So the main thing here is just figure out if you're breathing too much or too shallow, and wherever the carbon dioxide is, that is going to be treated as an acid. There we go. All right, now when we talk about acid-base disorders in the kidney, we're usually talking about metabolic problems. So secretion of hydrogens and stuff like that, being able to filter or excrete bicarbonate as well. So this is going to regulate, so primarily the kidneys are going to regulate your bicarb. Now it does take a little bit longer for compensation mechanisms in the kidney, because obviously it could take days for the kidney to regulate this by urination. But whereas you could change your breathing pattern for respiration, second by second. So another thing to keep in mind is that acid phosphate and ammonium are considered acids. So if you have metabolic acidosis or even respiratory acidosis, how do you correct the fact that you have too much acid? You try to pee more acid out, okay? So if you have chronic acidosis, you try to get rid of that extra acid by peeing it out. Okay, so so what are some situations where you want to get rid of acid? Well, what happens if we're breathing too shallow, right? So we're increasing our carbon dioxide in the body, which means we're not breathing it out. So if we're hypoventilating, that could lead to respiratory acidosis. Also, if we have, for whatever reason, a decrease in pH, which by definition, acidosis, what do we do in the kidneys? We try to increase our acid secretion. We're trying to compensate. We have extra acid for whatever reason. We have extra acid, and by having that, we want to try to get rid of it the best way possible. Okay, we talked about this. This is that paroxysmal aciduria. If you have hypokalemia, the only way to bring back, so that's because you're getting rid of potassium. The only way to bring that back is to get rid of hydrogens, okay? Now, this is what we were saying. This is that Cone syndrome, primary hyperaldosteronism. So in this sense, you have too much aldosterone, you're keeping sodium, you're getting rid of potassium. And again, the only way the body at the terminal point can get the potassium back is to get rid of hydrogens, okay? So that'll stimulate alkalosis because you're peeing out too much acid, okay? So again, this is a kidney problem. So this could lead to metabolic alkalosis. If you get volume contraction, we talked about this, we're activating the RAS system. So we're gonna tense down on the vessels. We're gonna also stimulate hydrogen secretion. Again, but this is because of the increased aldosterone. So you can see that here, increasing aldosterone, increased potassium secretion. So you're gonna end up with hypokalemia. To try to fix that, you're gonna get rid of extra hydrogens. So this is this paroxysmal, or sorry, I was saying that wrong, paradoxic aciduria. Meaning if you're in a state of metabolic acidosis, why do you keep peeing out acid? You want to keep the acid, but you can't because you're sacrificing that to try to bring back potassium. Okay, and then briefly, again, this is a term 4 issue, loop diuretics. The whole goal is to stop the sodium from being, well, both diuretics here, the whole goal is to stop the reabsorption of sodium. And by doing that, you're keeping the water in the urine to get rid of it. So you're diuresing the patient. Okay, again, those thiazides can lead to hypercalcemia just because they're located at the distal convoluted tubule where PTH is active. Now, if you have, primarily, you compensate with the other mechanisms. So if you have a problem with respirations, you compensate with the kidneys. Again, that takes a little while. If you have a problem with the kidneys, you could compensate by ventilating, changing your ventilation. That's more of a quicker compensation mechanism. But you can actually, if you have some sort of metabolic acidosis, if the kidneys are okay, you can also compensate with the kidneys. So again, if you have metabolic acidosis, quickly, with a quick response, you can have respiratory, change your breathing patterns. But if the kidneys work okay, you can also try to compensate metabolically through the kidneys. Okay, and let's see. Okay, now let's say we have acidosis. Remember, we said that to get rid of the, to try to correct for the acidosis, we're going to get rid of acid in the urine. So we're going to increase phosphate and ammonium excretion to try to decrease the acid in the body to go back to equilibrium. Metabolic alkalosis means you have your blood's too alkaline. So we know bicarb is treated like by increasing bicarb loss, you're bringing the body back to equilibrium. So that's our way of getting rid of these alkalotic agents, okay, by getting rid of bicarbonate. So acidosis, get rid of extra acid. Alkalosis, try to get rid of the extra base. These are the ways the kidneys are going to compensate. This is from first aid. It kind of puts everything there. Some of the stuff you don't really need to worry about just yet, but it's all there. Just memorize this. I mean, you can just break it down by looking at the values, but if you memorize what quadrants go with what, those are easy points, okay? But if you correlate it to low bicarb and high pH, that would obviously be respiratory alkalosis and whatnot. Another way of breaking it down, acidosis versus alkalosis here. But yeah, so you obviously look at your pH and what's going on to cause the pH. Remember, we treat carbon dioxide as an acid. Okay, and this is just from first aid. And what you do, remember these red arrows are your compensatory mechanisms. How are you compensating for it? So general sense, if you have a metabolic problem, you compensate with respiration. If you have a respiratory problem, you compensate with the metabolism. Can y'all hear me okay? It says my internet's unstable. I guess it's okay. Okay, cool. Yes, all right. So now we'll break down how this actually works. So respiratory acidosis. Acid means we're holding on to acid. Carbon dioxide is our acid. If we're holding on to it, that means we're breathing too shallow. We're not breathing enough. We're hypoventilating. That's why we have so much extra carbon dioxide or extra acid. Okay. So again, if we were going to compensate for this, we would have to do it metabolically. You can't, if you're hypoventilating, that's the problem. I mean, you're not going to be able to correct it by just starting to hyperventilate. Like something's actually causing the hypoventilation, like opioids or whatever, which is the example they like to use. So if you're having a problem with your breathing, you have to compensate with the kidneys. Okay, so chronic respiratory acidosis means chronic hypoventilation. You're holding on to carbon dioxide. To compensate, you're going to try to hold on to your base, right? You're in acidosis, so you hold on to the base to try to fix it. Causes of hypoventilation, the main one they talk about is opioid use. Chronic or extensive opioid use can lead to hypoventilation. I guess technically, yeah, they could ask about phrenic nerve. Remember that supplies the diaphragm. Also, these COPDs and lung diseases, you're not getting proper gas exchange with the carbon dioxide. Again, you're holding on to carbon dioxide. That's an acidosis. Now, alkalosis means you are breathing too quickly. You're getting rid of the acid. If you get rid of the acid, you have alkalosis, so hyperventilation. Anxiety, they always talk about anxiety as the reason for that, or one of the reasons for that. So again, you would have to compensate with the kidneys. Chronic respiratory alkalosis. So how do we compensate? Well, if we have alkalosis, then we want to try to get rid of our base to bring us back to equilibrium. So if we could try to get rid of the base, we could try to get correct for this respiratory alkalosis. Now, hyperventilation, okay, anxiety is the one they mostly talk about. Fever too, hypoxia, again, you're hyperventilating, you're getting rid of too much carbon dioxide, you're in an alkalotic state. Now, metabolic acidosis means you're either holding on to acid or you're getting rid of too much base. So here we talk about getting rid of bicarb, which would lead to acidosis. So, a lot of times this is due to diarrhea. Diarrhea is the one I talk about here. It'll cause decreased blood volume, but you also lose a lot of bicarb in your diarrhea. So, so how do you compensate for metabolic acidosis? By breathing differently. So if we're in an acid state metabolically, we want to get rid of our acid through the respiratory system. So how do we get rid of acid? We want to hyperventilate. Okay, that's our compensatory mechanism. And again, there is, nothing in medicine is black and white. So even though you have a metabolic problem and you're going to compensate with the respiratory system, you can sometimes use the kidney as another compensatory mechanism. So again, metabolic acidosis, you're going to hyperventilate. Okay, great. You're trying to correct it, but you can also try to pee out more of the acid. Okay, again, to bring us back to equilibrium. So just make sure you sit with these and talk yourself through these, because it's a lot of words and a lot of shifting values, and you just need to make sure you have it straight on the exam, because this is the most important thing for this exam. All right, diabetic ketoacidosis. Y'all will talk about this later. This happens in type 1 diabetics. But again, acidosis, this is a metabolic acidosis. So due to this insulin deficiency, they can't regulate their blood glucose. They end up making ketones, and that's acidosis, or acid. That ends up with acidosis. Okay, so keep that in mind as one of the causes for metabolic acidosis. Anion gaps are just these unmeasured anions, right? So cations always going to be sodium. The anions we primarily worry about are bicarbonate chloride. So if you have, or a HAGMA, or is what they call it, high anion gap metabolic acidosis, that's usually these unmeasured anions. I do believe you'll have to, yeah, there we go. You'll have to know this equation. So this is our anion gap. So if it's a non-anion gap metabolic acidosis, it'll be outside of the range of these things. So just make sure you know that equation, and that would be our standard anion gap. They'll probably give you that though. Okay, now metabolic acidosis, what could happen? Yeah, again, we talked about diabetic ketoacidosis, lactic acidosis if you're working out a lot and you have anaerobic metabolism, and chronic renal failure as well. Can cause a lot of problems, but decreased excretion of these sulfates or phosphates. Remember, we said phosphate was an acid. If you can't get rid of it, you can have acidosis. But also, not only holding on to acids, but getting rid of too much base can lead to it. So like I said, the one they'll probably ask you about is diarrhea. You're getting rid of the bicarb. Renal tubular acidosis. Yeah, again, it has acidosis in it, so it's metabolic acidosis. Acetazolamide is going to prevent the reabsorption of bicarb. So it's a medication they use for altitude sickness. So if you use that, you can eat too much, or it can lead to increased excretion of bicarb. Okay, switching, metabolic alkalosis. So in this sense, we're holding on to bicarb, or holding on to base. Same thing as saying we're getting rid of too much acid, right? So either way, but we're in a state of too much base. So how do we compensate? So if we have metabolic alkalosis, then we want to try to hold on to our acid. How do we hold on to acid? Where's the word? Oh, here in red. We hypoventilate, right? By hypoventilating, you're not breathing out the acid, so you're holding on to it. Okay, everything works concurrently. Now, again, that trick, even though you're in a state of metabolic alkalosis and you're compensating with your breathing, the kidneys can also try to get rid of this excess base, excess bicarb, okay, to try to bring it back to equilibrium. Causes of metabolic alkalosis, remember the acid in your stomach, so vomiting, right? Vomiting will cause loss of acid, so it can lead to alkalosis. Nasogastric suction, same concept. You're sucking out a bunch of acid. Antacids will neutralize the acids, so you can have alkalosis. And then, yeah, we talked about Cone syndrome, right? And then again, with this, we have that paradoxic aciduria. So we're getting rid of hydrogens, therefore alkalosis. Okay, diuretics, yeah, you probably don't need to really worry about that right now. Okay, mixed disorders. The key thing, the only thing is that in mixed disorders, your carbon dioxide values and your bicarb values will move in opposite directions. So if you're compensating, when you look at the values, they should always move in the same direction. So if they move in opposite directions, you have a mixed disorder. I don't think they asked us this, but I think Cassidy or Kishore said they had 1 or 2 questions on mixed disorders on their exam. So just make sure you know that this can happen, okay? All right, and then situations, the one that probably, if they do ask you, is aspirin poisoning. So aspirin is an acid, so it'll cause metabolic acidosis, but the aspirin also stimulates the respiratory center. So it'll cause respiratory alkalosis, meaning you're hyperventilating. So it's a mixed disorder. You get hyperventilation because it messes with the breathing center in the brain. So you get hyperventilation, but you also get too much acid in your system. So it's not going to cause a respiratory alkalosis and a metabolic acidosis. Okay, so a little tricky there. Okay, now this is how we're going to do these. This is what you need to focus on. So first thing is you look at the pH and you say, does the patient have acidosis or alkalosis? Then you're going to ask yourself, well, what's going on? Are they vomiting? Do they have diarrhea? What's the problem? What is the primary problem? Okay, metabolic or respiratory. Okay, and then you're going to ask, well, is it chronic or not? Meaning, that are they able to compensate for it? If it's some sort of acute problem, they probably haven't compensated. But if it's a chronic problem, then you need to look for compensation. Once again, memorize these quadrants. That'll be a couple points on the exam. We're going to go through some examples in a second. And then if you're one of these people that likes these crazy graphs, then it's there for you too. All right, so normal ranges, they should give you these on the exam. Honestly, if you just memorize these, it'll make your life a little bit easier. Just know I use 40 for your arterial concentration of carbon dioxide, and 24 is good for bicarb, and 7.4 for pH. So it should vary significantly from these ranges, and you can go from there. All right, so cystic fibrosis, that causes lung problems, increased productive cough. Okay, so it could have a fever. Right, so we'll go with that. So first step, acidosis or alkalosis. Acidosis, right? Should be 7.4. It is 7.3, okay? Second step, okay, so acidosis. Second step, what caused the problem? Is it respiratory or is it bicarb? Now, my first thought is, I know cystic fibrosis has a lot to do with lung problems, right? Coughing up lungs, plus a fever too, that's never good for your breathing. So I would lean towards a respiratory problem. So let's check it out. PCO2 should be 40, it's 50, so it's elevated. What does this mean? You're blowing off more carbon dioxide, okay? So if you're getting rid of acid, that would be respiratory alkalosis, right? Then we could check our bicarb, 24, so we're in a normal range. So it seems like this is an acute process. There's no compensation going on, but you are breathing too heavily, okay? So yes, respiratory problem. Sorry, wait, hold on. Should be, I'm sorry, okay, wait, let me correct myself. So PCO2 should be 40, right? If it's 50, that means it's high. That means you're holding on to it. That means you're not breathing it out. Okay, so the patient's actually hypoventilating. Okay, sorry about that. So yeah, so if you have too much acid, you're holding on to it, so you're not breathing as much. Okay, so respiratory problem, respiratory acidosis, because you're holding on to this acid. And then we can say that since the bicarb is in the normal range, there's no compensation yet. Okay, so let me just say that one more time to make sure we got that straight. PCO2 should be 40, it's 50, so you're holding on to the acid. So this is a state of respiratory acidosis. We can confirm that with our pH, acidosis. So respiratory acidosis means you're holding on to the carbon dioxide, which is your acid. which means you're not breathing as much. That's how you're able to hold on to it. Okay, so hyperventilating, holding on to the carbon dioxide, therefore respiratory acidosis, and that makes sense, right? Now we check, is it acute or chronic? Well, our bicarb hasn't changed, so it seems like it's acute, no compensation. Okay. All right, vomiting right away. What's your thoughts? He's getting rid of acid. So right away, I would say, looks like metabolic alkalosis. Okay, so let's look into it. First step, 7.56. So alkalosis, right? Makes sense. He's throwing up hydrochloric acid. Now we're going to ask ourselves, even though we have a hunch, right? We want to check everything. So we want to ask ourselves, what is the problem that's causing the alkalosis? Does this cause alkalosis? No. Carbon dioxide is an acid. If you have increased this will not cause alkalosis. So that can't be the cause. Okay. Bicarb, if bicarb's supposed to be 24 and it's 32, does that cause alkalosis? Yes, right? Because you're holding on to the base. Makes sense, okay? So we can definitively say that of these two, this one is the one that would cause alkalosis. So we're in a state of metabolic alkalosis. Now we have to ask ourselves, well, is this acute or chronic? Has the patient compensated? Remember, the respiratory compensation is pretty quick, right? You know, second by second. So you could definitively say the reason that the patient is hypoventilating, right, holding on to acid, is to try to compensate for this. Yes, you would expect the patient to hypoventilate, increasing your carbon dioxide, increase acid. So this is an immediate response. So hope that makes sense. So first we could say easy enough, alkalosis. Which of these is causing alkalosis? No, that doesn't cause it, but this does. Metabolic alkalosis. Why is this off? Because you're trying to compensate for this alkalosis by hypoventilating and increasing the acid in your system. Okay. Again, you have if it's a metabolic problem, you can compensate with respiratory with your respirations pretty quickly, but you can also have renal compensation, but that takes